And then for FGFR testing, I think there was some consensus that you would do it when a patient is diagnosed with metastatic disease. And it's not going to be their first-line treatment anyway, and you have lots of time to determine their status, and if they progress on first-line treatment, then you would have that in your back pocket for deciding on second line.
Just to comment very quickly on that, I agree with Peter. I do testing in the first-line setting immediately after diagnosis to have the results available for later lines of therapy for clinical trials or dafitinib. And the point I want to make is there is an adjuvant clinical trial that also in the Europe, single-arm phase 2, and there's a randomized phase 3 trial in the US with infigratinib versus placebo after nephroureterectomy or cystectomy. So in the context of that trial, because infigratinib is an FGF receptor inhibitor, we would do testing in that setting after surgery in the context of that trial. Tilman, you had something to say?
Yeah, I think one argument is to do the FGFR testing in a very early setting is that these patients, if they are third or fourth line, actually in many cases have a very significant tumor dynamics. And if you have to wait for the result of the FGFR3 testing or FGFR testing, we've experienced some patients that actually deceased within a very short time span. And so it's important to get the diagnosis, but I agree with Peter that it probably makes sense to test or do the sequencing at time of metastatic disease, because it's very likely that there will be evolution of the molecular changes from the localized disease to metastatic disease.
Mm-hmm. And maybe just before we move on to the localized setting, a lot of these trials, especially the adjuvant trials, they're using disease-free survival as an endpoint. I'd like to hear all of your comments on what do you think of that endpoint in bladder cancer? Is that a valid endpoint? Is there a good surrogate for overall survival?